Looking at the nervous system, pretty simple here. There is a lot of terms here as well, but not quite as many as what we just looked at. And it's a little bit more contained because we're looking at specific parts and not the entire body. However, the nervous system does travel through the entire body with its nerves. But we can basically divide it into two parts, being the central nervous system, which is the brain and the spinal cord, and then the peripheral nervous system, which is all of the different nerves that spread out then throughout the rest of the body and all the way down to even our toes. So all the way out to our utmost extremities. Here we see sort of a gross anatomy look at the central nervous system, showing our brain and then spinal cord, and then the very bottom of that, the cauda equina, which we really won't talk too much about today. It's called the equina because it kind of looks like the mane of a horse. It's really fascinating, actually, if you guys ever are in anatomy and physiology, to be able to go ahead and take a look at the cauda equina, showing it, because it's a really fascinating piece of our biology. It's really cool. Looking at the chart then on 648, of course, the brain itself, pretty self-explanatory, but can be broken down to the cerebrum, which is the majority of the brain that we're looking at. And then sort of like within the cerebrum, there's kind of like this hollow space where the ventricle is located inside of that. And the ventricles themselves are these hollow spaces that are filled with cerebral spinal fluid. But that's kind of why this one looks almost transparent inside of that, because it's inside of sort of like medial inside of where the brain is in that pocket. And then you have the cerebellum, which is just this little part down here at the bottom of the cerebrum. So the majority of the brain is the cerebrum, but the cerebellum then is down at the bottom. The cerebrum itself is doing most of your sort of like sensory, large motor skill types of movement. And then the cerebellum would be more like involuntary, like your breathing and heart rate. Breathing specifically then in the brainstem. So you've got your cerebrum would be 1, cerebellum would be 2, and then you've got this brainstem here, which would be 3, those sort of like 3 parts of the brain. Those 3 parts of the brainstem, then you see the midbrain, the pons, and the medulla oblongata. The medulla oblongata there is really the most important one, because it actually has a function, and it's specifically for respiration and heart rate. If you get that damage, that medulla oblongata damaged, then really the patient's respiration and heart rate control are going to be messed up. They're going to have sometimes life-threatening issues because of that. Following that, of course, is the spinal cord, and it's covered by the meninges, which is the protective sheath that covers around it, and we'll take a closer look at that before finally down at the bottom we end with that horsehair type of mane, the cauda equina. Now, of course, coming off of the spinal cord, you've got vertebrae all along. That's the spinal cord is running through the center of all of the vertebrae, but then you've got nerves running off of all of these areas in between the vertebrae, as well as nerves coming out of the brain themselves, those cranial nerves that we looked at. So we kind of talked about the function of the nervous system in general already. This slide discusses those in a little bit more detail. We discussed the cerebrum and the things that it does, so like all your memories, temperature, pain, again, some major skeletal muscle control is all there. Divided into that right and left hemisphere, so you do have on both sides. And then again, the ventricles in between, that's filled with the CSF, and we'll talk a little bit more about the CSF down the road. But that CSF, it runs inside of the brain, and then it also runs all the way down through the spinal column inside of the meningeal sac. And it acts as a fluid type of suspension for the brain. So as you're moving around and your brain's not just smashing against the skull in the room that's inside of the skull. It's not like a tic tac in an empty container that you can hear rattling around. That suspension fluid is a suspension that allows you to do a lot of things with your brain and not have trauma take place. Now, if you're going to headbang really hard, or you're in a whiplash type of accident or any type of physical trauma that causes you to really get your head whipped violently, what happens is your brain starts moving and then your head stops, but your brain, because it's in that fluid, keeps moving until it then smashes the front of the skull. And so then you have immediate trauma, but then that trauma there actually causes a reverberation through the brain and then causes excess trauma as it sort of bounces back, just like a wave in a swimming pool sort of bounces back and forth. We see interestingly, not just trauma where the brain hits, but then also that rebound trauma, opposite of that as well. Talked about the cerebellum and the brainstem, the pons, medulla oblongata. Spinal cord, we mentioned this yesterday, but it travels down near the sacrum, but does not go down to it. So here this is parsed out, telling us that it travels to the level of the second lumbar vertebrae. And then, of course, the nerves are cutting off through those, from the spinal cord through those vertebral spaces. And we'll see that here in a little bit. Dura mater, if you guys look at the page on 649, this is the layers of the meninge. And so again, that meninge is just like a sac or a lining around the entire brain and the spinal cord. So it's going around the entire thing, and it's making this sealed system or this sealed sac that's filled with fluid. If you get any type of puncture in that sac, such as if you have an epidural when you give birth, or if you're in some type of trauma that causes a tear to be in that meninge or that dural sac, then that fluid can slowly leak out. And it is recycled anyway. I'm trying to remember, I think it's about 200 milliliters per day is our brain actually secretes CSF, and then it circulates itself and recycles itself through the bloodstream, but it's constantly filling and then recycling itself. But if there's a leak in your meninge that's big enough to let more than that 200 mils per day out, then it can't keep up with how much CSF is needed. And then we'll get what's called brain sag, because that suspension, that brain's no longer floating in that fluid anymore. And the brain will actually start sagging and start touching the skull. And you'll get these just crazy bad headaches. And people will often misdiagnose it for migraine headaches, but it doesn't respond to any of the therapies. This is most common in after pregnancy when women have had an epidural, where you actually go in and puncture the dural in order to produce the anesthesic effect. But when it happens spontaneously, it oftentimes gets misdiagnosed. Looking at the three different layers of the meninges, the dura mater, and again, you can look at this picture on page 649. That's the outermost layer. And so if you're looking at the picture on 648, sort of that's that blue glowing thing that's around the brain and the spinal cord, that's the dura mater. And it's the tough outer layer that's providing protection. And then the arachnoid is the middle layer, and it's fairly delicate. And you can see there that it's basically just almost the inner layer of the dura mater. They're really closely touching each other. But then there's a space between the arachnoid and the pia mater. And you can see the pia mater, as shown in the picture on 649, is like sort of that inner orange column that is wrapping itself around the vertebrae. And then it's got the nerve fibers coming out of them. So you've got this space, the subarachnoid, underneath the arachnoid layer of that. So if we're going to draw sort of what this looks like out on the brain, so let's call this our brain. That's the cerebrum, cerebellum, and then you've got your spinal cord. You've got your, I'm going to draw this really big to make it obvious, but you've got your dura mater out here. And then you've got your arachnoid, which is basically just the inner lining of your dura mater. They're pretty much like touching on each other, sliding back and forth. And then you've got this larger space in between that's wrapping almost like a visceral lining right around the organ itself. And then you've got all of that space in between here. And that's where all the CSF or cerebral spinal fluid is at, causing that suspension. And the reason why I kind of go into this much detail is because you can have an issue where there's a bleed underneath the dura, but between the arachnoid space. We would call that subdural because it's below the dura, but not below the arachnoid. If it actually goes below the arachnoid into that subarachnoid space, we would call that a subarachnoid bleed. And then you can also have bleeds that are out here. So if our cranium's out here, right, then you can have a bleed in between the cranium and the dura mater itself. Just kind of keep that in mind as we move forward, and we'll see a few of those terms a little bit later, and a couple of images that kind of demonstrate that, but I wanted you guys to have that knowledge before we get there. That was a look at the central nervous system. The peripheral nervous system, like I said, that's basically from the spinal column out, not the spinal column, but the nerves coming out of the spinal column and then heading out into the extremities. We talked about the cranial nerves. We've got 12 pairs of cranial nerves that actually come out of the cranium or out of the brain itself. Most of those are ocular, so eye, ear, facial nerves, things like that. And here's a picture of that. So it shows us all of the different cranial nerves that run down into the body, like the accessory nerve for the accessory muscles of breathing. And then the vagus nerve, which runs down and actually innervates the heart and the lungs and the digestive organs as well. 31 pairs of spinal nerves. And again, the spinal nerves then come off the spinal cord, and those are more or less our extremity types of nerves, where we're going to be going to a chiropractor if we have issues with our spinal column or nerve pain as a result of that. The term ganglion just means a group of nerve cells. So it's like a bundle of nerve cells, and it's outside of the central nervous system. So it's out in the periphery. And then glia is a specialized cell or support nourishment, as it says there, of the nervous tissue. The neuron itself is what conducts the impulses. So if we were to go further out from our spinal cord out into our muscle tissues themselves, we have these neurons. This is kind of like what a neuron is going to look like. Then at the end of it, it's shooting out typically acetylcholine, ACH. And then over here, you've got the muscle. This is like striated muscle tissue, and it's got all these sensors. And you've got this space then called the neuromuscular junction, or the NMJ, right here, which is this whole section in between the neuron and the muscle, where all of these little acetylcholines are then going out of the nerve and then over to the muscle. That's what activates muscle movement. So your brain tells your nerves, like, hey, we want to move. This is how we want to do it. I want to put one foot in front of the other. It shoots through those nerves and it shoots out acetylcholine, and then acetylcholine finds its home in the muscle, and that activates that muscle to actually be flexed or moved. And then that's how we move. And it's amazing that this is so fine-tuned that we can have the motor skill to be able to write our name with a pen, or to make an incision inside of someone and go in and cut the tiniest little fiber and then suture it back together, tie a fishing line in a knot, braid your own hair when it's behind your back, you name it. All of these things, there are these fine motor skills that are created by these just tiny microscopic movements inside of our body. It really is pretty phenomenal how all of that works together. That being the case, there's a lot of disease that can follow with this, and myasthenia gravis is one of them. And we talk about muscular dystrophy, muscular sclerosis, Guillain-Barré. There's other like botulism, lots of different other neuromuscular diseases or conditions that can cause problems. Running on the outside of these nerves is something called myelin. It's a myelin sheath. So it's a lot like the matter or the meninge of the spinal cord, but it's of the peripheral nervous system. And that myelin sheath can actually become degraded by disease, in which case then that nerve is just exposed. And if it's exposed, then it can be really painful because anything can interact with it and sort of stimulate it. And anytime that nerve gets pinched or hit, causes lots of pain. A demyelinating condition can be quite painful, and also then cause issues with that acetylcholine release. There's other problems that can actually just break that nerve down and decrease the acetylcholine to be released. And if that's the case, the muscle isn't going to receive the acetylcholine sensor that it needs to then go ahead and move. And then there's still other diseases that take place over here in the muscle where it's unable to accept the acetylcholine. And so lots of different reasons why we could have sort of like a neuromuscular type of injury or disease condition. So then combining forms based off of the nervous system, we can see these here. That's on page 652. Here we see basically what we've already talked about. So cerebellum, cerebrum, breaking those down into their combining forms, dura, encephalo, meaning the encephalo just basically relating back to the brain itself. So we'd use that with something like encephalitis or encephalogram, but it basically is just referring to the brain itself as we're talking about that. Ganglion, of course, we just mentioned those. The glia, we just talked about that, the meninges, and so on. So pretty straightforward. The radiculo, and rhizo, it's kind of a strange term, but they all go back to nerves themselves. And sometimes is used to discuss just the spinal cord or the vertebral column. So you might see that in a couple different ways, and it's like, okay, well, that's just kind of a weird and confusing look at it, because we really haven't used those terms to describe any of the anatomy. So that can be kind of a difficult one to wrap your mind around or to remember. Aesthesio, such as if we're talking about like anesthesia. So that basically is, if we break down the word anesthesia, the aesthesia part of it is just the feeling or the sensation of feeling. And then the ana would be without. So when you go to the anesthetist, you have the anesthesiologist put you under. What they're doing is basically removing the feeling from you so that you don't feel what's going on. Now, there's always two parts to putting someone under. You need to anesthetize them so they don't feel what's happening, but you also have to paralyze them so their muscles don't respond to the incision that's about to be made. You can't simply just anesthetize someone so they don't feel it, but let their muscles do whatever they want to, nor can you paralyze someone so their muscles don't do anything, but yet they can still feel. You got to use both a paralytic and an anesthetizing agent. Mento or psych, such as mental or psycho, psychic, psychiatry, with just meaning to mental, talking about mental disorders, things of the brain, things of the neurological system. Mono being one in its root. Phase, polio, quadri, just different terms. Phase such as dysphagia or dysphasic, meaning the speech aspect of it. Polio, as far as like the gray matter of the brain. So again, that's kind of a different one that we really haven't talked about. And there's so much more anatomy like that we're not talking about. Like we're actually talking about the different areas of the brain tissue itself that much. So we're kind of just doing a quick overview of all of that. And then quadri, we'll see sort of some other terms like peri and hemi down the road here just a little bit in referring to different areas such as quadriplegia or paraplegia or hemiplegia. Some suffixes, iatrist like in psychiatrist, iatry, psychiatry. Ictal is kind of an interesting word, relates to seizures. And so we'll use a lot of ictals with like the suffixes, with like prefixes like predictal or postdictal, meaning before or after or during a seizure itself. And then paresis is that slight paralysis of, such as if we had like a quadriparesis, that would be a slight paralysis of the, of whatever we're relating that to. Disease and disorder terms built from the word parts. Here we're seeing a little bit more of those word origins. So cerebellitis, back to the cerebellum. So remember, we had the cerebrum and then the cerebellum. That sometimes is difficult. Like, how do I differentiate between the cerebrum and the cerebellum? I always use the L's in the cerebellum to mean it's the lower section. And so if I kind of just think about the brain as the big brain, and then it's got this little pocket back there that's the cerebellum, I think that the L in cerebellum means it's the lower section. And so that's the difference of cerebrum and cerebellum. And that's how, like, if I read it in a word like cerebellitis, that's how I'm knowing, okay, what part of the brain is that talking about? Obviously the cerebellum, but which part was that? That's that lower sort of hindbrain of the back. So it's underneath the cerebrum. Anyway, that's how I remember it. Maybe that helps you, maybe not, but hopefully there's some type of word that can help you remember those types of issues. Duritis, so again, the dura, encephalo or encephala, back to things of the brain. Gangli, meningi, the glio, all of those, again, words we know. It's just what's the ending. Pathy, seal, like we've talked about the meningioseals before, the umbilical seals, diaphragmoseals, those types of things. The omas, we see some omas on this list. Of course, the itises, the malacia, meaning softening. Common suffixes, just the new word roots for this chapter. Here is a meningomyelosil, which we learned about in the neonatology section. This was specifically showing spina bifida, which is like the common name for meningomyelosil. And what we see here then is that spinal column actually protruding out and it will actually poke out of the back of the baby's body in a lot of cases. And that we would basically just call that spina bifida, but the technical term for that is meningomyelosil. Continuing neuritis, neuropathy, neuroma, polio. We see that rhizo again here at the end of this list. So going back to that, thinking vertebral column, again, a lot of common words here just sort of being reused. But the bottom one there, subdural hematoma. So hematoma here is talking about basically like a blood clot or blood outside of its vessel where it should not be. And so that's what the hematoma aspect of it means. And then subdural, remember, this is below the dura mater, but it's between the dura mater and the arachnoid. And so it's in between that thin little seal there that we described earlier. Some disease and disorder terms not built from word parts. And some of these are obviously familiar probably to you guys, such as like Alzheimer's disease or ALS, which is also known as Lou Gehrig's disease, amyotrophic lateral sclerosis, different types of palsies. Here they're using Bell palsy, where you basically have like a hemiparesis, where one side of the body basically you lose muscle control, and so you get this sagging. In this case, the patient's eye, they cannot keep it open anymore. You can actually see how the cheek is sagging and also the lip is sagging a little bit. If this patient were to smile, basically it would look like this, where the one side is sagging and the other side moves up. Not to be confused with the diagnosing of a stroke. Okay, we'll see a Bell palsy type of presentation with stroke patients, very, very common, okay? The difference being Bell palsy is something that is going to most likely be a known neurological issue that that has been slowly oncoming. They get it checked out. Now, maybe the first time they have it, it's like they get rushed to the hospital and they get evaluated for a stroke. But after that, they get diagnosed with Bell palsy. And then the palsy itself, the paresis, kind of comes and goes. So it's not usually a permanent paralysis, but just like a paresis, so a temporary palsy. But when you do have a patient that you're all of a sudden, almost instantly, they go from being fine to now they're slurring their speech, they're drooling from one side. You tell them to raise their eyebrows and one goes up and the other doesn't. You tell them to smile and they kind of have that one smile up and the other side hangs down. You put their hands out in front of them and you say, okay, put your hands on top. You say, okay, push up on your hands, or you push down on them, and one side they can keep you up, but the other side you push it down really fast, meaning they've had the paralysis or a paresis to one half of their body. That acute onset is what's going to differentiate sort of like a Bell palsy versus an acute onset of stroke. But we can see some pretty similar symptoms from that. So it's just kind of nice to be aware of those. The cerebral aneurysm and embolism. Remember we talked about an aneurysm before, where we said it's like an outpocketing or a dilation of the vessel. So in the brain, if you've got your artery and then you've got this widening aspect of your artery, this part's the aneurysm. And that's a problem because this has become very thin. That wall of the artery is super thin now because it's stretched out. An increase in blood pressure can cause this to rupture and blood to spill out. Car accident, you don't know you've got this aneurysm, but then all of a sudden you have a car accident and the trauma causes this to break, and now you've got blood spilling out of a brain artery into your brain space, wherever that artery happened to be. That blood then it's going to cause two problems. One, it's going to diminish blood flow to the rest of the brain. That's an issue. And then two, all of this blood is going to be pooling in whatever area it's spilling out into, and it's going to increase the pressure inside that area, which is then eventually going to be pushing in against the brain tissue and start smashing or crushing the brain tissue. That itself is going to cause major acute problems that can lead to permanent problems for these patients. It's emergency time at this point. They need to, one, fix this, but they need to come in and evacuate that now hematoma in that space, wherever it happens to be, to get that old blood out of the brain so it stops putting pressure on it. But ultimately, they got to come in and patch that. So this is like that Grey's Anatomy, Dr. Shepard, emergency neurosurgery type of event, right? So this is why they get paid the big dollars, and they're on the TV shows, and they're always handsome and making $1 million driving race cars, okay? Something like that. Not real life, Now we're looking at different types of dementia, and the chart for this is located on page 665. I'm not going to go through each one of these. You can see the definitions for each type of dementia listed there, but just understand that, dementia is a form of degenerative brain disease where multiple different factors can lead into it. And so it's not just one strict pathology that's leading to it, but multiple, and they're not all exactly the same. The end result is some type of consistent confusion. Sometimes it's transient, it comes and goes. Sometimes it's worse, sometimes it's better. But overall, it continues to progress and get worse as the patients age. So the first one on the list here, Alzheimer's, is probably the most common and most well-known one. As patients age, it is responsible for about 3/4 of all dementia cases. So that's why we hear most about it. The other one there, vascular or multiple infarct dementia. This would be related to some type of bleed, hemorrhage, or aneurysms that bust that are leading then to a lack of blood flow to parts of the brain, and that would be like an infarction, or just the fact that blood is leaking into the brain and causing problems there. That would be the vascular aspect of it. Central nervous system infection, such as from herpes virus, can infect the central nervous system and lead to dementia. So it's important that that gets treated. Parkinson is one that you hear about quite a bit as well. Not always includes dementia, but as it progresses and gets worse, as patients get older, it can usually include dementia. The Wernicke-Korsakoff is just due to alcoholism. And then normal pressure hydrocephalus, we know the hydrocephalus being brain cephalus and hydro being water, extra water within the brain, but normal pressure. So it's not this extreme pressure causing major problems. And this is easily treated with a shunt, which is just a tube that is going to drain spinal fluid or any type of fluid from one part of the body to another. And this would be like a cerebral shunt. And we'll discuss that later in one of our word charts as well. Diseases and disorder terms not built from word parts. So we see things like intracerebral hemorrhage. And if you look at page 664, there's a picture of a skull with a brain on it on the top left-hand side. And it shows on the right-hand side of that brain, sort of this reddish, purplish formation in the middle of the brain tissue. And that would be intracerebral, so inside of or intracerebral, the brain tissue or the cerebrum. And then you also have on that same page the subarachnoid hemorrhage, which is listed over here on the right-hand side of the column. That, remember when we drew the picture, that's a bleed that's happening below the arachnoid level. So you've got the dura mater, then you've got the arachnoid level. And so this bleed that they're showing here is below the arachnoid level, between the brain itself and arachnoid layer. The sciatica is also a pretty important one that we hear about a lot. Lots of patients with slipped discs or degenerative disc disease, herniated discs. And we see a lot of that with athletes. We see a lot of that with like construction workers, people doing very physical types of jobs. But we also see it because we have a large obese population in America, and that leads to a lot of undue compression onto our vertebral bodies and the intervertebral discs, which then herniate and cause problems with the sciatic nerve compression. And if you look on page 663, just turn a page back, top right-hand corner, you can see that sciatic nerve, and it actually runs all the way down from the lower back to your toes. And so oftentimes people with this sciatic nerve compression because of a disc then will have this numbness or this tingling or this extreme discomfort in their legs. And so you hear people talking about they've got a sciatica or they've got a sciatic nerve. That's basically what's being discussed and what they're talking about. Inversion tables actually work, in my opinion, very well for this type of problem. Getting the weight off of your discs a couple times a day and allowing them to get re-moisturized and the fluid to get back into them is really quite effective. And I oftentimes just recommend inversion tables to people with all kinds of back issues. Obviously, you want to be under the direction of your doctor. TIA, or transient ischemic attack. Basically, this is like a miniature stroke. So the patient will have all the signs and symptoms of a stroke, but then they'll go away. Like before they even get to the hospital, it's gone. And it can happen several times a day. It can happen once a week, or there's really no predicting it. Basically what it's just saying though is that at some point you're probably going to have a much larger stroke. And so we need to try to figure out what's going on with that patient. And so oftentimes they'll get put on blood thinners in order to help prevent having a big, massive stroke. There's subarachnoid hemorrhage. We already talked about that. So the hemorrhage or a bleed out below the arachnoid level in the brain. And shingles, we've mentioned that before as well. That's another herpes type of virus, which is resulting in sort of like these skin type of breakouts or these skin type of lesions. Another contributing factor or result of that herpes zoster virus, which is the same virus that's responsible for chickenpox, by the way, or varicella, is this like nerve inflammation or irritated nerves. So it can be quite irritating and painful. Here we see that image of the hemorrhagic stroke, the one on the left there with the intracerebral hemorrhage or a subarachnoid bleed. And then on the right, we see the ischemic stroke. And so the two differences between the two strokes, one is caused by a clot. So we see the cerebral thrombosis. They're causing a problem where it's actually stopping blood flow. Whereas in the hemorrhagic stroke, you have actual blood vessels breaking instead of just being clogged. Both of those are strokes. They'll both lead to sort of the same type of droopy face, slurring speech, drooling, weakness on one side of the body versus the other. All of that's going to look exactly the same. But the big thing to remember with that is that treating this patient are very different. You cannot treat these patients the same way. Treating the ischemic stroke is to go in with a clot buster and blood thinners and try to eliminate that clot and eliminate future clot formation to then restore blood flow. But if you try to give clot busters and blood thinners to a patient with hemorrhagic stroke, you've basically just signed their death certificate because they've got a broken blood vessel that needs to clot and it needs to fix itself, yet you're giving them a non-clotting substance in order to prevent clots. And that's going to cause that bleed to get worse and that patient ultimately is going to expire. So that's a surgical intervention as opposed to usually a pharmaceutical intervention with the ischemic stroke. And so while most of the symptoms are going to be exactly the same throughout, how we treat that patient is super important. Continuing to move through some of the surgical terms, ganglionectomy. So ganglion we know is sort of like that bundle of nerves, and then ectomy we know is the excision of something, so excising a nerve bundle. And then the rest of those, you see a lot of the neuro, so lots of neuron types of issues there. And then we just have the lysis, plasty, rhapheotomy, ectomy, all of those things which we've learned about in previous units. And then the last one, radicotomy or rhizotomy, again, leading back to like the nerve roots of the vertebral column, and the otomy being an incision of that. So you're incising a nerve root. There's an example of that listed in the book on 668 or here on this slide, where you can see they're actually just clipping that posterior nerve root in order to discontinue that actual communication of that nerve back to the spinal column. And what that's going to result in then is that nerve is no longer going to be sending that sensation back to brain. So that may in fact cause a lot of relief for your patients. They may not have the pain or the numbness or the tingling that they felt previously, but they may also lose a little bit of feeling and a little bit of control as a result of that nerve root being cut or discommunicated. So it's kind of giving up one issue for another issue. It's just a matter of what you can actually tolerate as far as that patient is concerned. And it usually is sort of like a last case scenario. You don't want to cut a nerve like that and discommunicate, but if nothing else has worked, then sometimes that's the last option. Looking at a couple of diagnostic terms built from the word roots. So we've seen things like the CT in the past, and angiography we've looked at the past. So at page 670 here, you can see top left-hand page is an image of a angiography. And again, the angiography is looking at the vessels inside the brain. Excuse me, it's actually at the bottom of 670. That's the angiogram that you're looking at there. And then the myelograph is the one on the top left hand. And so showing, if you look at the figure 1514 at the bottom of page 670, showing you all of those blood vessels inside of the brain. And that's, that's pretty phenomenal to be able to see all of those. And then you'd be able to identify if there's a blockage in any one of those areas in order to then go on with your treatment. Some neurodiagnostic procedures. The most common one there you see is the EEG, or the electroencephalogram. This is oftentimes used to treat seizure patients and to keep an eye on them to see, when and how are they presenting with their different types of seizures. We also do this pretty frequently. Well, actually every single time we do a polysomnography exam. So polysomnography is sleep study, multiple sleep study. And basically what that's doing then is looking at the brain waves to see what stage of sleep your patient is in. So there's 4 different main stages of sleep. And throughout the night, you kind of bounce in and out of most of them. And then REM sleep is extremely important for the recuperation of the brain. And without going into REM sleep, then we wake up the next morning and we don't feel rested. We're actually more likely to fall back asleep during the day, not be able to concentrate. And actually, it's quite dangerous and leads to all kinds of other physical health issues because we're not sort of rehabbing our body at night the way that we're supposed to. So we hook up these leads to the skull, recording the electrical activity of the brain, and lets us know what stage of sleep we're in. If a patient does not breathe normally at night, then they don't go into the proper stage of sleep. And that's why obstructive sleep apnea can be so damaging to a patient's health. Diagnostic imaging, flip a page over to 672, and here we see a CT scan of the brain. There on the left, figure 1515. That's kind of like all the other CT scans we've seen in the past, except for we've typically been looking like at the thoracic cavity or the abdominal cavity. Here is just what the brain looks like. MRI and PET scan are both on page 673, and you can see the MRI of the lumbar vertebrae there, when they've got a black arrow actually showing a compression fracture. And you can see, it's kind of hard to tell, but look at how big those other lumbar vertebrae are, like how thick they are. They look like nice marshmallows. But then you look at this one that the arrow's pointing at, and it looks like you smashed it between 2 graham crackers. So it's all smushed down. And so that's showing compression. And then you can see how it's sort of got these dark bands on the center of it, where the other ones don't have that dark banding. That's because the increased density of that compression and the compression fractions itself is causing you to have a slightly different appearance when you do the MRI scan. And so that's indicating that compression fracture. And then a PET scan, probably heard it termed as a PET scan, positive emission tomography. Basically, you can see it there showing increased brain activity in that hot spot. So that red spot that's listed in the picture, showing you where exactly the seizure is taking place within that patient's brain. A couple other items of note, the potential studies and then the lumbar puncture are listed as well in that list. The lumbar puncture being the most common. A picture here. Lumbar punctures are typically done for patients that have meningitis. And so sometimes kids will get an acute meningitis, and oftentimes pediatrics, and we'll have to do lumbar punctures on them. Adults will get meningitis as well. And so lumbar punctures are sometimes common there. And you can see what they're doing. It's actually puncturing through the dura mater and through the arachnoid into that subarachnoid space. And you can actually see the cauda equina down there, those nerve endings down in the lumbar. We do these lumbar punctures there because we're less likely to hit the spinal cord and actually cause major issues. If we were to do it more superior to the body, more cephalad or up into the thoracic or cervical spine, then we've got that big, thick spinal cord there and all of those other nerves to where it'd be likely we would, if we poked in too far, we're gonna hit something and damage it severely. Whereas if we go in here, we're pretty safe not to cause any major nerve damage by doing this puncture. When you do that, of course, you are causing a communication then out of that dura mater, and you've got the possibility that you're going to now be leaking cerebrospinal fluid. So we mentioned cerebrospinal fluid leaks. We talked about most commonly if you have an epidural, when you're going to have a baby, then it's common to have a CSF leak afterwards because that hole that they did the epidural inside the dural space there, it just didn't heal properly. Likewise, if you are having a patient that needs a lumbar puncture and we go in and puncture that, we take out some of the fluid, we test it. If that puncture site doesn't heal right away properly, some of that CSF is going to leak out of it, and you could end up with that brain sag and those migraine type of headaches that we discussed yesterday. Looking at our complementary terms word chart, this is on page 675. Lots of the words that we are expecting to see. Anesthesia, we've all heard that before. This is what you get when you go under surgery. Again, the anesthesia is that feeling sensation, and the A, so anesthesia, is just without that feeling, and that's what you want your anesthesiologist to do when you're going into the hospital. Aphasia similarly is without, and then phasia is speech, so without speech. Cerebral, craniocerebral, having to do, of course, with the brain, and then the cranium, and the brain. Dysphagia would be improper speech or inability to, it's not aphasia, but it's a dysphagia. So there's something wrong with the speech. Encephalosclerosis, the sclerosis we've learned about in the past being a hardening, and then the encephalo of the brain, hardening of parts of the brain. Gliocyte is site meaning cell, and glio, we know the glia cells, so that's just a regular term in referring to the glia cells themselves. Hemiparesis we're going to talk about here in just a second. I actually have a slide to show you a picture of that, but hemi being half, and paresis meaning sort of a temporary lack of control or movement. So not exactly like a complete paralysis or complete being paralyzed, but just a period of being paralyzed. Hemiplegia, the next one, top of the right-hand column, would be like a full-on, one half of your side is completely paralyzed. The rest of these, actually the interictal, I wanted to make a comment about that. Remember, ictal refers to seizures. And so interictal is within a seizure. So if someone bites their tongue during a seizure, you would say that they did that interictal. And we'll see that term used here on this slide, where we have postictal and preictal. So postictal being after a seizure and pre being before the seizure. So there we've seen all during, before, and after the seizures referring to that ictal. And then we also see quadriplegia on this list as well, and subdural. And we've mentioned that subdural before being below the dural space, but not below the arachnoid space. So between the dural space and the arachnoid space, there's really not much space there. It's more or less just like a slimy lining that the two rub against each other so that you've got some frictionless motion, but you can have bleeds into the subdural space that is between the arachnoid and the dura. So here's the types of paralysis that are being described in that first one. You can see the right-hand side of that patient is highlighted in that it is a hemiparesis or hemiparalysis, in that the right-hand side would be affected with the paralysis. The second picture here, the one in the middle, is just lower extremities. You're only got 2 out of the 4 extremities are being affected. So that's what we would call a paraplegia. So para meaning just 2 or half. And then the bottom, you've got all 4 extremities being affected. And so that's would be a quadriplegia or quadriplegia. Looking at some complementary terms not built from word parts, I want you guys to pay special attention to the top 2 on this list, afferent and efferent. You will learn about these. It'll be extremely important for you guys to know those 2 terms in anatomy classes. And it's basically talking about the direction of flow away from the central nervous system via the nerves. And so if you're going to be flowing, or the way I like to remember it, if you're going to be exiting the central nervous system. So if I'm going to exit the central nervous system, that means I'm going to be going away from it. I'm going to be out from the central nervous system. E is efferent or afferent. Efferent is exiting. So it starts with E, efferent, exit. That's going to be leaving the central nervous system. Whereas coming back into the central nervous system is afferent. And so that can be really hard for me, as sort of like I like to use letters and the alphabet to memorize things. So I usually like to say, oh yeah, like away, that starts with A and it's going away from the central nervous system. That's afferent, but that's incorrect in this case. You have to think exit. You have to use that term exiting for efferent, and that's meaning leaving. And then coming back to the central nervous system is afferent. Some other words on there that are fairly common, like gait, that just is talking about a person's, how they walk, their mobility. So a lot of physical therapists are going to be using that term gait, as well as orthopedic doctors. Incoherent, hopefully I'm not incoherent in how I present the material to you. Basically, that just means that you can't really understand what the person is speaking. For example, someone comes out drinking all day, all night, whatever, and they come home and they're just babbling, right? Because they're drunk. They would be incoherent. What they're saying, sometimes you can't even understand what they're saying. And when they do say stuff, it makes no sense at all. So that would be like incoherent. But we will see that medically with dementia patients, patients on medications, if they're coming out of anesthesia, if they're on too much pain, well, not necessarily even too much pain meds, but it can be an appropriate amount of pain meds. It can cause patients to be incoherent. Seizure, we've talked about that quite a bit already, but it's word itself. If you look at it, we can't break it down, and it doesn't make sense unless we know what it's actually talking about. And then that word shunt, which we explained before, such as a cerebro shunt, where you actually have they would place a small tube in your head and it would run down your neck and then into your abdomen. And then that is going to drain some of that excess fluid out of your cranium down into your abdominal cavity. That's going to help you from having those high pressure hydrocephalus types of situations. Syncope means the patient faints or passes out. Oftentimes that is related with unbalance or vertigo as well. When patients do have syncopal episodes, then it's important to sort of look into that and figure out what it is that's causing the syncopal episodes. And the list is long. It will take a while to figure out what is actually causing it in that patient in some cases. Concussion, coma, convulsions, consciousness, all of those are pretty straightforward terms that we use in almost all everyday type of life. Some behavioral health terms. So behavioral health is sort of the term that gets thrown onto psychiatric patients. And at the hospital, they have a behavioral health unit. They've gone away from using the term psych unit or mental health ward, these types of terms that might be actually more medically consistent and descriptive for something that maybe is more politically correct in saying behavioral health. If you buy into that type of thing, personally, I prefer just to call it what it is and try not to put a stigma on it, because there can be a stigma. I mean, I get that. And we've got to caution ourselves against that, because you say, well, yeah, they're the patients in the psych ward. That stigma is, oh, like, okay, they've got some type of mental disorder and what's going on? That's crazy, right? Whereas that's not always the case. You could be in the psych unit for lots of different reasons, and it's not schizophrenia, bipolar disorders, multiple personality, all sort of like the big things you hear about in all of the horror movies that just sensationalize that type of thing, when really they're disorders and conditions, and they're really sad, in fact. But behavioral health covers a whole lot bigger of a spectrum than just sort of the psych and mental disorder types of patients. One, maybe it helps to do away with some of that stigma, but then it also provides a more accurate representation of the whole of what that unit is able to do. So you see lots of the psych. The psych just is referring to that mental aspect of medicine and looking at those types of treatments. And so the psychiatry, the study of it, psychiatrist, the person who studies it, again, psychology, more of the study of it, psychologist, and so on. Some of the behavioral health terms not built from word parts. Here we see like the anorexia and obsessive compulsive disorders, as well as like bulimia. So those are two good examples of behavioral health terms that are not necessarily the stigma of your typical psych patient. Those eating disorders are truly psychiatric conditions. And so they require counseling and treatment. Sometimes they, just like depression and some of these other types of psych conditions, sometimes they never completely are resolved. Sometimes medications help, sometimes counseling helps, but doesn't mean it's necessarily going to always be resolved. And then we have things like ADHD, which we've all heard about, the attention deficit, autism spectrum disorders. ASD would be an acronym for autism spectrum disorder. Then you see like major depression, schizophrenia, PTSD is also on this list, panic attacks and phobias, or being scared of certain things irrationally, be a definition of phobia. And so we've mentioned a few of those acronyms, and here are a few more, like the ADHD, the OCD, we saw those. CNS for central nervous system, PTSD, of course, CVA for cerebral vascular accident, CSF for cerebral spinal fluid, TIA is that transient ischemic attack, lumbar puncture, LP, SAH, subarachnoid hemorrhage. I think we've pretty much looked at all of these throughout the course of our chapter, but here they are all on one slide for you to review. And that finishes chapter 15 of the nervous system.